All right, so let's get into endocrine disorders. And so I've broken up endocrine disorders into a few different, categories based on, what gland is it related to? Because sometimes it helps with these endocrine disorders to kind of group them together. So let's start by talking about pituitary disorders. So, like I mentioned, we're going to break it up into body systems. We're going to talk about the pituitary disorders, thyroid disorders, adrenal disorders, and so on and so forth. So the pituitary is pretty much like a hodgepodge. It's kind of like a Texas melting pot. It has a whole bunch of hormones that it's responsible for. I have a couple of them highlighted because the other ones are more related to your reproduction. And while that can have effects on everything like that, the disorders that we're going to talk about mostly affect your growth hormone, which is your GH, your ACTH hormone, and your TSH, which helps stimulate your thyroid. So let's kind of break this down. So one of the main pituitary disorders you're going to need to know about is what's called acromegaly. And this is a problem of excessive growth hormone. So I have too much of this hormone. And the most common cause, and you're going to kind of see this across the board for endocrine disorders, a lot of the most common cause is going to be a tumor. So they get a tumor on the pituitary gland in their brain. And that's what causes a lot of these disorders. So when it comes to growth hormone is responsible for helping you to build up muscle tissue, bone growth, muscle mass. And so when most people think of acromegaly, they actually think of Andre the Giant. So if you're a wrestling fan like I am, Andre the Giant is probably one of the most famous people to have acromegaly. And you can see how big this is, a normal sized human being over here next to him. And this is Andre the Giant up here. They call him Andre the Giant because, literally we caught his probably double the size of most people. And that's because he had too much growth hormone. These people that have this excessive growth hormone or this acromegaly have a deep voice. As much as they have these really big muscles, they're actually really weak. And so they're large muscles, but weak muscles. So, appearances and everything. And they also have thickening and enlargement of all their tissues. So look at how big his hand is right here. His hand is almost the size of this guy's entire face. So thickening of the hands, the face, the feet, as a whole, everything is larger or bigger in these patients. Well, this might not seem like a big deal, but there can be a lot of complications. And I guess that we caught picture didn't show up well, so I apologize for that. But effectively, it's kind of just saying overall, like what are some of the things you're going to see. But some of the biggest complications you're going to see in a patient with acromegaly are going to be sleep apnea, which can lead to cardiovascular disease. Diabetes is a common complication, and also decreased life expectancy. Most patients with acromegaly die of cardiovascular disease or colorectal cancer. So how do we diagnose and treat it? The best test is what's going to be called an IGF, or a glucose tolerance test. And effectively, this is looking at a lot of the issues that come up with growth hormone related to insulin. And that's going to be one of the best measures that the patient has this. We also can detect if they have a tumor. So we can do an MRI or CT to see if they have one of those adenomas or tumors there. And then, treatment is going to be, surgery or radiation if there's a tumor present. Treatment is not a cure. The damage is already done. So kind of think of like with diabetes, how once a patient, once we diagnose diabetes, a lot of times damage has already happened before that. So even as we start to treat it, the patient may still experience the effects of the damage that's already been done. We can try to help make the symptoms better. There's drug therapy, so we want to try to give drugs to decrease growth hormone like dopamine agonists or octreotide. And then we can also give growth hormone antagonists, or things that are going to work against growth hormone. So there's a variety of medications and treatment. But again, this is one of those that once a patient has it, it's really just trying to prevent complications and prolong their life and decrease their symptoms. So let's talk on the other end of the spectrum. So I can have too much growth hormone, but I can also have not enough. So when I have hypopituitarism, where I'm not secreting enough of my hormones, this can be for all those hormones. Remember that long list of hormones I had on the first page? So this is for all of your hormones. Usually it is just a few of them, but it can be all of them. But effectively, you're not making enough of your pituitary hormones. And the patient's going to look different depending on which hormone is not being produced. So remember with growth hormone, when we had too much, we had that big muscular kind of person. Well, with less growth hormone, you're going to have weakness, fatigue, decreased muscle mass. They're going to be smaller than average. If they have less FSH or luteinizing hormone, those are hormonal or reproductive hormones. And so you're going to have those kind of changes, problems with your period, problems with your libido, things like that as well. They can have low TSH or thyroid stimulating hormone that can lead to fatigue, weight gain. And then they can also have decreased ACTH, which can lead to weakness, pale or dry skin. So as a whole, everything's kind of slowed down. It's weak, tired, not working the way that it's supposed to. You're kind of small and chunky, you're not going to be the same size as a person who does not have this disorder. So we usually diagnose this based on their hormone levels. Their hormone levels are going to be low for all of those hormones. We can also find that tumor through MRI or CT, and we give them whatever they're missing. So with this one, we can actually just replace their hormones. Now that might sound very simple, but that hormone replacement therapy can be really rough on the patient. So we're going to replace whatever they're missing, whatever hormone it is that they're low in. And then if there's a tumor, we're going to do surgery and radiation to remove it. All right, so that was the first part of the pituitary. That's what we call the anterior pituitary. So let's talk about the posterior pituitary. And you have ADH and oxytocin. We're not going to talk about oxytocin. That's what you think about when you're thinking about like childbirth and things like that. But ADH is what we're going to focus on. So what is the deal with ADH? What kind of problems can happen? So there's two disorders, and that's the one nice thing about endocrine is they always go opposite. There's always like one, and then here's the opposite. So we already talked about here's too much growth hormone, and then not enough of the pituitary hormones. They always kind of go opposite. So it's just kind of getting down, making some flashcards, maybe with some signs and symptoms about the major things that are different, or kind of like, kind of feeling out like what are these patients going to look like would be really helpful. So for ADH, it's also known as antidiuretic hormone. And so pretty much like if you have too much ADH, you're going to be like this first glass here. You're going to be fluid overloaded. It's you have too much antidiuretic hormone. And what's a diuretic? A diuretic makes you pee. So if I'm antidiuretic, then I'm holding on. I am not peeing. So with ADH, they hold on to too much. SIADH, they hold on to too much fluid. They can also have the opposite, which is what's called DI or diabetes insipidus. This is not diabetes mellitus. We'll talk about it, but it's the opposite where they have not enough ADH. And so they're actually going to be peeing everything out. So if you're kind of already thinking about it, this is going to be a lot of fluid and electrolyte balance issues. So let's go to first talk about SIADH. This is too much ADH. So I am holding on to too much antidiuretic hormone. And if I'm antidiuretic, I have too much not peeing. So this is the glass half full. The tank is full and overloaded. I am holding on to everything. I am not letting go of anything. So the patient's going to show signs of fluid overload. They're going to have weight gain, fluid retention. They're going to have, and we're going to talk about these, so don't get too confused yet. They're going to have what we call decreased serum osmolality, which is in the blood. So the amount of particles that are in their blood is going to be low because it's diluted. And then their urine osmolality is going to be high. They're not peeing out a lot. So what they are peeing out has a lot of particles in it. I have pictures later, I promise. They're also going to be hyponatremic. And this is the most concerning thing about SIADH is that hyponatremia. Anything that alters your sodium imbalance way too low or way too high can cause you to have neurological signs. And you can actually go into a coma and have complete brain swelling and brain death, because that's what happens when your sodium gets off and water follows it. And so with these patients, we really got to watch that sodium closely. And that's going to be our biggest concern, those neurological changes. So in order to diagnose SIADH, I'm going to measure, like I mentioned, their serum osmolality. So that's telling me how many particles are in their blood, like how thick is their blood, how much is their particles versus water. And we're going to compare that to the urine osmolality, how much like fluid versus particles is in their urine. We're also going to check their sodium levels and get a specific gravity. And a specific gravity is very similar to the urine osmolality, where it tells me how many particles do I have in my urine. So I actually drew out some pictures for you guys because I know that you love my crazy artwork. So in a normal person, we have a balance up like here. There's some water here in the middle. There's a variety of particles. But when things like SIADH or DI happen, then we start to have these abnormal processes. So this is I'm looking first, like let's look first at the serum osmolality. And so this is measuring how many particles versus fluid are in the blood. So if I have, if I have high serum osmolality, that means I have not a lot of fluid, but a lot of particles. So look at the difference. This is all looking at the ratio of how many particles versus fluid. So if I have someone who has a whole lot of particles, but not a lot of fluid, that would be someone who's maybe dehydrated, who doesn't have a lot going on, then they're going to have high serum osmolality because it's osmolality is saying how many particles are present. So in high serum osmolality in the blood, there's not enough water in the blood, there's too many solutes and particles. And then in low serum osmolality, which is what we're going to see, in these patients that have diabetes, SIADH, the symptom of inappropriate antidiuretic hormone, they're going to have low serum osmolality. If you remember from before, let me go back a slide. They're going to, they're going to have decreased serum osmolality. So in other words, when we're going back here to our picture, these patients, remember, they're not peeing. So where is all the fluid going? It's going into their blood. So they have a ton of fluid in their blood. And because there's so much fluid in their blood, everything gets diluted. They have too much water and not enough solutes and particles. And in reality, they still have plenty of solutes and particles, but there's so much water, it dilutes it. So this is thinking in the blood. If you have high serum osmolality, think concentrated blood, someone who is dehydrated, does not have a lot of fluid. And then for a low serum osmolality, there is low amounts of particles because they have so much fluid that it dilutes all those particles. So this is talking in the blood. So let's talk about in the urine, because remember, we compare what's going on in the blood versus what's going on in the urine. So on the opposite end of the spectrum, again, in normal urine, there's a balance of fluid and particles that come out in the urine. But when I have high urine osmolality, what's happening is I am peeing out a bunch of particles, but I'm not letting go of a lot of fluid. So this is what happens in a patient with SIADH. They're not getting rid of their fluid because they have too much of that antidiuretic hormone that's causing them to hold on to all that fluid. So they're not peeing out a lot of fluid. All they're peeing out is a lot of particles. So it's all about that concentration of like that ratio of one versus the other. So these patients are going to have dark, concentrated urine. On the other end, in a second here, we're going to talk about diabetes insipidus. And when we're talking about that, they're going to be peeing. And so they're going to have a lot of fluid coming out. And because there's so much fluid, there's going to be less particles because there's so much fluid in comparison to what the particles that are coming out. So in other words, a patient with SIADH is going to have a low serum or blood osmolality because there's a lot of fluid, not a lot of particles in their blood, but they're going to have high urine osmolality because in their urine, they're not peeing it out, it's staying in their blood. And so all they're peeing out is just a little bit of particles. Whereas when we talk here in a second about diabetes insipidus, it's the opposite. So diabetes insipidus, they are peeing everything out. So they're dehydrated. They're going to have very concentrated blood. Their blood is going to be concentrated because all their fluid is getting lost in their urine. But then when we look at their urine, they're going to have low urine osmolality because they're peeing everything out. It's going to be clear, diluted, because effectively it's all that water is getting lost. So it's really this diabetes insipidus and SIADH is looking at where is your fluid. SIADH, it's in your body, in your blood. DI, it's going out in your urine. That's where your fluid is. And so it's all about just kind of knowing where is that fluid. So how do we treat SIADH? So we're going to obviously monitor their eyes and nose very closely, those sodium levels to make sure they're not getting, abnormal, and we're monitoring those neurological assessments closely. We're also going to do a fluid restriction because remember, this patient's overloaded. They have all that extra volume in their blood, so they're going to need a fluid restriction. We're going to treat their hyponatremia, and we're going to give them 3% saline. I know you're thinking, wait, this person's overloaded. Why would we give them IV fluids? We're giving them very low doses of a lot of particles. So usually when we give 3% saline, it runs at like 40 milliliters per hour. We're not trying to give fluid, we're trying to give salt. We need to raise their sodium up slowly to prevent their brain from swelling from that low sodium. We might also give furosemide or ADH antagonists to start to try to beat against, like we want less ADH. And so we're going to try to work against that and help them to get that fluid off so that we can get them back to a normal fluid and electrolyte balance. So on the other end, there's diabetes insipidus. This is where I have not enough antidiuretic hormones. So there's, we call it pretty much is the opposite of what we talked about before, where the patients in SIADH, they're holding on to a lot of fluid. They're not peeing. These patients, they are peeing too much. They're getting rid of everything. The tank is empty. They're peeing out everything. If you want to go back to cardiac, their CVP and their preload is going to be low because they are peeing everything out. So there's a couple different causes of diabetes insipidus. And remember, this has nothing to do with diabetes itself. All that it is a process of an issue with your antidiuretic hormone usually. So you can actually get DI just from taking in too much water. So if you're drinking a bunch of water right now, don't panic. It only happens, I'm talking about for people that have psychological disorders that cause them to drink like toilet bowls full of water. So it's very rare for it to happen that way, but I have seen it happen. Usually most types of diabetes insipidus come from either a neurological problem, like we talked about, a problem with your hormone, or a kidney problem, because in order to respond to antidiuretic hormone, your brain has to produce it, and it has to, your kidneys have to respond and be open to listening when your brain tells you, hey, it's time to pee. So in other words, it can either be a brain problem or a kidney problem. So the neurogenic, like I mentioned, that's hormonal. That means you're not making enough of that ADH, that antidiuretic hormone, because you're not making enough. All you can do is pee. It usually happens after brain injury, surgery, or if there's an infection. And usually the good thing is it's responsive to a treatment that's going to help to replace that and get that working again. Nephrogenic can be from medication or like renal damage, like kidney failure and things like that, where your kidneys are just going to say, hey, I know you're telling me to hold on to more urine, but I'm not doing that. So it's like, it's trying that, like, even though you're making ADH, the kidneys are not responsive to it. So this patient's going to have signs and symptoms of dehydration. They're going to have polydipsia, so a lot of extreme thirst. Because think of it this way, kind of think of like, it's a nice way to remember it, even though this is not diabetes like you guys know it. This is diabetes insipidus, not diabetes mellitus. They have a lot of the same symptoms. They have the polydipsia, polyuria. They don't have the polyphagia. They just have those two. But effectively, they're going to be thirsty because they're peeing everything out. They're dry. Polyuria, they're peeing constantly. They're having large quantities of dilute urine. In other words, remember back to those labs where they have a whole lot of water, not a lot of particles. They're going to be weak, severe dehydration. They can have hypotension, tachycardia, hypovolemic shock. And they also have the opposite of SIADH. They have hypernatremia. Because if you remember, they're peeing everything out. So in their blood, there's not a lot of fluid and a whole lot of particles. So that makes the sodium appear to be higher. And again, this can cause a lot of brain issues. So I need to watch their mental status closely. So this is the opposite of SIADH. They have increased serum osmolality. So in other words, in their blood, there's not a lot of water, whole lot of particles. They have decreased urine osmolality. So they're peeing everything out. So they have a lot of fluid, not a lot of particles in their urine. They have increased serum sodium. And usually one of the ways that we kind of help to diagnose it is their urine output is greater than 200 milliliters per hour. It has a low specific gravity. And remember, specific gravity is very similar to that osmolality, saying how many particles are in the urine. And remember, if you're peeing out a whole bunch, and it's diabetes insipidus, it's usually that you're peeing out water and you don't have a lot of particles in there. So that's what that's looking at, is what is the amount of particles that's in the urine compared to the amount of fluid. So how am I going to treat this? So effectively, it depends on the cause. If it's a neurological cause, like I had a brain injury and I'm not making that hormone, then I'm going to, of course, replace the hormone. We give a medication called DDAVP. I'm also going to give fluid therapy, so hypotonic saline, because remember, they have too much sodium. So I'm going to give them hypotonic saline or D5W to kind of help rehydrate them. I'm going to monitor their blood glucose because you can have an osmotic diuresis, which can lead to problems and issues with your blood glucose. I'm also going to monitor their urine output, their hemodynamics, their level of consciousness, their specific gravity. I need to do really accurate I's and O's, and I can give them medications to decrease their thirst. On the other hand, if it's a kidney issue, if I have the hormone that I need, but my kidneys just aren't responding, then those, like the normal things that I used for the neurogenic, aren't going to work. So I need to do things like a low sodium diet, thiazide diuretics. We also give Indocin, which is an NSAID, which strangely enough, I know you're thinking like kidneys, NSAIDs, aren't those bad? But this one actually helps increase your renal responsiveness to ADH. So yes, that kind of breaks down what am I going to do with neurogenic versus nephrogenic. So that's pretty much pituitary disorders in a little fun box for you. I know that they're a little complicated. Endocrine disorders are a little bit more high maintenance, but hopefully this was helpful to kind of get you started. It's all about kind of breaking down what's the one extreme versus the other. And so trying to break down those differences so that you can better understand these disorders. So hope this was helpful.